A patient case report. Hello. Welcome to the presentation of our patient case report. Please join us as we take a deeper look into the diagnosis, pathophysiology and treatment of multiple myeloma. Let me introduce our patient. This is Jane Doe. She is a healthy, 63-year-old fit female with a normal height and weight. She led an above-average active lifestyle for her age. That included regular yoga, playing club tennis, and cycling twice a week. She ate a balanced diet and had no known allergies or chronic diseases. The patient also had no family history of any specific diseases, osteoporosis or blood disorders. But in 2014, while playing tennis, Jane experienced a great fall. After the 5th week of intense lower back pain, Jane decided to visit a doctor. Since the painkillers and physiotherapy seemed to bring her barely any relief from her consistent back pain. After doing a thorough examination and family history report on Jane, the physician requested an X-ray of her spine. The results came back revealing a hairline fracture on Jane's third lumbar vertebra. But upon further evaluation of the X-ray, abnormal density of the lumbar spine was observed with possible lytic-like lesions on some of the surrounding bone tissue. The physician decided to do a full blood count workup on Jane, since she also mentioned feeling exhausted and not her usual self. The blood work pointed out a few concerning factors such as clonal plasma cell levels at 11% that should normally lay between 2 to 3%. A potential hypercalcemia problem with a value of 2.6 millimole per liter, that ranged on the upper end of acceptable levels. After these tests were performed, the doctor had enough evidence to make a positive multiple myeloma diagnosis.
Multiple myeloma is a form of blood cancer. It starts with one or more changes to the DNA of a single stem cell in the bone marrow and is characterized by the abnormal multiplication or proliferation of plasma cells. Plasma cells are differentiated B lymphocyte white blood cells capable of secreting immunoglobulin, or antibody. These cells play a significant role in the adaptive immune response, namely, being the main cells responsible for humoral immunity. In a healthy individual, the body's plasma cells will produce antibodies to help fight infection. But in patients with multiple myeloma, these plasma cells produces faulty antibodies and forms numerous tumors throughout the bone marrow, prohibiting the production of normal blood cells. It is a malignant systemic blood disease that is fatal in most cases. As mentioned, multiple myeloma develops in the white blood cells. These cells are also called B lymphocytes. The B cells forms into plasma cells where they then overproduce inactive antibodies that the body cannot utilize. The inactive antibodies accumulates in the body and spread to different organs. Multiple myeloma is the end stage of a multi-step neoplastic transformation of the plasma cells. It proliferates from a plasma cell disease spectrum ranging from monoclonal gammopathy of undetermined significance, smoldering multiple myeloma, clinical multiple myeloma, and, on very rare occasions, Plasma cell leukemia. The disease process is insidious, with end organ damage occurring over numerous years. Multiple myeloma is the second most common blood cancer worldwide, representing 10% of all hematological malignancies and 1% of all cancers. The risk of developing multiple myeloma increases as people get older. Most cases occur in people who are at least 65 years old. The average age of people diagnosed with multiple myeloma is between 66 and 70 years old. About 37% of people with multiple myeloma are younger than 65 at the time of diagnosis. A few decades ago, the average life expectancy of a patient positively diagnosed was at best 2 to 4 years. But over the past few decades, scientists and doctors have developed a better understanding of the disease. More advanced therapeutic drugs and treatment options became available that can be more effectively combined to treat multiple myeloma. This led to an increased life expectancy of 6 to 10 years. Multiple myeloma is often diagnosed based on a variety of tests, the patient's symptoms and the doctor's physical exam of the patient. A positive diagnosis of multiple myeloma can include a combination of the following tests, but must always include the presence of a plasma cell tumor, proven by biopsy, or a plasma cell count of 10% or more in the bone marrow biopsy, accompanied by at least one of the following: high blood calcium level, poor kidney function, low red blood cell counts also known as anemia, holes in the bones from the tumors found on imaging studies, such as a CT, MRI, or PET scan, or an increase in one type of light chain in the blood that exceeds another type by 100 times more than the other. Various tests using blood samples are used to measure different levels of specific elements in a patient's blood. A complete blood count test is used to measure the levels of red cells, white cells, and platelets in the blood. Blood chemistry tests include levels of blood creatine, albumin, calcium, and other electrolytes that will be observed and compared against normal values. Urine tests such as urine protein electrophoresis or urine immunofixation. This is a routine test done on a urine sample to assess the different type of proteins excreted by the kidneys. However, a urine immunofixation measures the levels of M proteins that is specific to patients with multiple myeloma. These M proteins are fragments of the abnormal antibodies produced by the neoplastic plasma cells. Quantitative immunoglobulin electrophoresis. This test measures the different type of antibodies in the blood. A high level of immunoglobulin G and A are most often found in high amounts in people with multiple myeloma. Serum-free light chains. This blood test helps detect, diagnose, and monitor plasma cell disorders such as multiple myeloma, primary amyloidosis, and related diseases. It is also used to monitor the effectiveness of specific treatment plans. Light chains are proteins produced by plasma cells. The test can detect the excessive free light chains that may be produced by neoplastic plasma cells and increase in comparative ratios, which indicate an excess of these clonal plasma cells. Bone marrow biopsy. Bone marrow core biopsy may be uncomfortable or painful, but must be performed. In a core biopsy, a special hollow needle captures a sample of the spongy bone in the marrow along with its contents. It can be done either at the doctor's office or at the hospital. These essential tests provide samples for the only direct means of examining the myeloma cells under a microscope. All other tests such as blood and urine test rely on indirect markers of what myeloma cells are doing. Imaging tests. X-rays can detect bone destruction caused by the myeloma cells. A CT scan uses X-rays taken from multiple angles, which are then compiled with advanced image programming to produce detailed images of organs and structures in the body. Magnetic resonance imaging or MRI has a high sensitivity for the early detection of marrow infiltration by myeloma cells. It has the ability to detect spinal cord or nerve compression in the presence of soft tissue masses and is recommended for the workup of solitary bone plasmacytoma. MRI is useful for imaging multiple myeloma because of its superior soft tissue contrast resolution. Jane was referred to an oncologist. Under normal circumstances, any treatment for multiple myeloma will only commence following the visual presence of several monoclonal cell growths, and then positively confirmed with tests after the first speculation of the disease. In our patient's case, the opposite was done, since the first two tests performed by her physician clearly confirmed the presence of multiple myeloma. Jane started her first round of chemotherapy within 30 days after her original appointment. Melphalan was the first form of chemo administered for a period of 3 months. The use of melphalan is standard chemotherapy for initial treatment against multiple myeloma. After the first course of chemo was completed, a blood test revealed that the defective clonal bone marrow plasma cells decreased. Borkade was provided as a maintenance drug in between the chemotherapy for 3 months, to observe how her body will react. Maintenance drugs are drugs used after chemotherapy and is said to be more important and less toxic to the body. These drugs include immunomodulating agents, proteasome inhibitors and monoclonal antibodies. After a positive reaction with the generic drug, the treatment of Borkade was continued. Thereafter, chemotherapy with melphalan was administered for the second round. Borkade was used again after this round of chemotherapy for a period of 3 months. This treatment plan was repeated 3 times in succession that lowered the cancer count in Jane's body.
The treatment plan showed positive results with a steady decline in her cancer markers. But less than a year since she started chemotherapy, Jane started experiencing troublesome side effects. During the phase of using Borkade after her third chemotherapy, Jane reported peripheral neurotrophy that caused numbness in her hands and feet, accompanied by balancing issues. The chemotherapy maintenance drug was changed to Velcade, and the generic drug, Borkade, was stopped. In the short term, the change in medication had a positive effect, relieving some of the peripheral neuropathy Jane was experiencing.
The new combination of Velcade and melphalan appeared to have an exponential positive effect, and remission was thought to be in sight. But then, almost a year since the change of her maintenance drug, Jane started showing signs of regression. This included a variety of symptoms, such as severe bone pain and fatigue. The oncologist stopped the therapy and reassessed her case. A new battery of tests were ran to determine just how fast and far the cancer has metastasized. The blood test revealed that the clonal bone marrow plasma cells were increasing. This was accompanied by an uninvolved serum-free light chain ratio of more than 100. This clearly indicating that the current treatment plan has lost its effect. After the unfavorable events, Jane was advised by the oncologist to proceed with the implantation of a port to ease the administration of chemotherapy. A chemotherapy port is a device implanted under the skin to deliver chemo drugs to a large vein in the upper chest. The port is usually implanted as a same-day surgical procedure under local anesthesia. A chemo port reduces the need for repeated needle sticks during chemo treatment. The oncologist also decided to switch Jane to carfilzomib lenalidomide dexamethasone chemotherapy, in an attempt to more aggressively target the cancer. The chemo could not, however, follow standard treatment because Jane had by this time lost a lot of body weight, and treatment had to be adjusted for her body size. The aim was to administer the chemo in 6 sessions, over the course of 3 weeks, and was to be repeated every 3 months.
The new regime of chemotherapy included the use of a therapeutic maintenance drug, bortezomib. This higher dose of chemotherapy and the new combination of drugs was a last attempt to curb the progression of the cancer. But very early on there were indications that Jane did not react to the drugs, and within a few months on the new treatment plan, the multiple myeloma seemed to have gotten even worse. Jane developed extramedullary disease, also known as EMD. This disease usually occurs when myeloma cells forms tumors outside of the bone marrow, and spreads into the soft tissues or organs of the body. While myeloma resides mainly within the bone marrow, EMD can be present at the time of initial diagnosis or occur when the disease relapses after treatment-induced remission. Jane's EMD tumors were picked up by a PET scan. The tumor's symptoms were first thought to be side effects from the strong chemotherapy. But 2 tumors were identified, one in her bladder and one in her liver. After biopsy was done and the tissue tested, it was confirmed that the tumors were malignant, and they were surgically removed. In 2019, after a round of blood work, the patient's hemoglobin count showed a further decrease to 6.4 grams per deciliter, and the patient was diagnosed with severe anemia. The chemotherapy continued as before, but the patient received supplementary blood once a week before chemo. Thereafter, the 3 weeks of chemotherapy was administered with a 3 months waiting period in between. The cycle was completed 3 times but drastically affected the patient's immune system. During the treatment period that started in April 2020, up until August 2020, the patient only received 3 doses of the prescribed 6 chemotherapy sessions. In August, the patient's blood work showed end-stage organ failure, accompanied by various end-stage multiple myeloma symptoms that included renal insufficiency and bone pain. The oncologist ended all chemotherapy treatment in September of 2020. Once treatment stopped, the main goal shifted from curing the cancer to palliative care, relieving the patient's symptoms and offer her as much comfort as possible. Jane deteriorated quickly and became weak and frail. Her pain was managed with an at-home morphine pump during the last month. Unfortunately, Jane took her last breath in January 2021. She lived with multiple myeloma for an extended period of just more than 6 years. The patient showed no prior plasma cell malignancies or signs and symptoms before the diagnosis. With advances in medical research and treatment, it is important to go for yearly checkups at a family physician. A possible better outcome might have been achieved if treatment was started earlier. Multiple myeloma is cancer that cannot be cured in most cases and can be diagnosed with blood test and imaging confirmation. With advances in research, it is better to start treatment earlier once it is suspected. Earlier treatment might destroy malignant plasma cells before it is untreatable.
Clinical technologists can be involved during the period of this patient's disease on various occasions. The patient experienced a lot of side effects of the chemotherapy, and a neurophysiologist could have assisted with a ULT with electromyography test to diagnose the patient's peripheral neuropathy. A nephrologist can also assist with dialysis in patients that experience acute or impairment renal failure. These therapies can increase quality of life and extend life expectancy with the help of clinical technologists.